This is lecture 3 of the urinary system. In this one, we're going to be primarily talking about fluid and pH balance. We'll actually start with just a little bit about secretion and some specific examples of how that works. We'll then get into fluid balance, how we gain and lose water, and the kidney's role in making sure that we end up with a balanced gain and loss, especially with paying attention to the role of vasopressin in the production of concentrated urine. That will lead us into talking about the medullary osmotic gradient, how vasopressin is able to do that, and we'll talk, in the process of doing that, we'll talk about the two types of nephrons and the phenomenon of countercurrent multiplication, and then finally we'll get into how the kidneys are involved in maintaining pH balance in the body. Okay, so we've spent some time talking about reabsorption. So now we've done filtration and reabsorption. Remember, of the 4 functions, filtration, reabsorption, secretion, excretion, the kidneys, specifically the nephrons, handle the first 3, and we've talked about 2 of them, so now it's time for a little bit on secretion. Remember, secretion is the selective movement of material from the blood to the urinary tubule. So even after we've filtered blood, we can move some extra material into the blood. Unlike filtration, which is only selective by size of molecule, secretion is always very selective for molecules. It's generally very specific. You'll have fairly specific carriers or transporters for the various things you want to secrete. We're going to look at a few specific examples of secretion. Specifically, we're going to look at, in the PCT, we're going to look at secretion of protons and penicillin, and then we'll mention a little bit more of secretion of a few other things. And we're not even going to really get into the details on these, but this is just for some examples. So in the proximal convoluted tubule, for example, we secrete protons by the use of a sodium proton exchanger. So if I were to look at a PCT cell, down here on this membrane, I'm going to have an antiport that allows sodium to come into the cell in exchange for H+ going out of the cell. Now, when exactly that would happen, that's going to be part of pH balancing, which will come at the very end of lecture 3. But this is one example of how this will work in here. We'll end up moving H+ out of this cell. Something similar can happen in the DCT, which we'll get into in more detail when we get into the pH balancing. The second example I wanted to mention is penicillin, which you're probably familiar with as an antibiotic. Now, very, very briefly, penicillin was one of the first antibiotics discovered, and it's hard to overstate how important that was. Bacterial diseases used to be lethal, just devastatingly lethal, and very, very common. People just kind of assumed that it was likely that you would lose one or more of your children to a bacterial disease. So when someone, Louis Pasteur, came up with this chemical, which you could take that would kill bacteria but do no harm to you, that was a game changer. That really changed public health and, honestly, human society. But when penicillin was first discovered, it was very expensive, very difficult to isolate. You had to extract it from mold. And, to make things worse, your kidneys actively secrete penicillin, like they do a number of drugs. They take penicillin and move it out of the blood and into the urine to get it out of the body quickly. Which means that if you're taking penicillin, it leaves your body rapidly and enters your urine. And in order for it to be effective against bacteria, you need to keep the penicillin in your body. So you have 2 choices. You can either take more penicillin more often, so that it stays in your body at a high concentration, which if it's expensive is a problem. Or you can reconsume your own urine, since the penicillin is in there now. And actually, the urine of people taking penicillin had a usable amount of penicillin in it. It was kind of an effective medicine. But people tend to fuss a little about consuming their own urine. Now, as it turns out, people figured out that there are some other drugs which use the same secretion transporters as penicillin. One common one that we use is probenecid. Probenecid is a medicine prescribed for gout, mostly, but it uses the same transporter as penicillin does. So if you're taking penicillin, and you take probenecid along with it, the nephron gets so busy secreting the probenecid that the penicillin tends to stay in the body. So it sort of amplifies the effect of the penicillin, causing it to remain in the body longer so you don't have to take as much. It's kind of handy that way. So now these days, penicillin is relatively cheap, and so I don't think we even usually bother taking probenecid along with it anymore. You just take more penicillin if you need penicillin. But anyway, it's kind of an interesting thing there. Now another example for secretion that's important is in the DCT, where if you remember from when we talked about aldosterone, we secrete potassium. Remember in the DCT, we had sodium-potassium pumps, which moved 3 sodium out in exchange for 2 potassium in. We also had sodium and potassium channels, which meant that the potassium that we put into the cell from the extracellular fluid and blood ended up here in the lumen in the urine. Now, we also talked about the drug aldosterone. And aldosterone amplifies all of this. It adds more pumps and more channels so that we reabsorb more sodium and secrete more potassium. You normally want to have some level of potassium secretion because it's very important that you not end up with too much potassium in your body. High levels of potassium disrupt EK around muscle and nerve and heart cells, which can be problematic. So, we want to secrete some potassium normally, but sometimes you can end up secreting too much potassium, especially when you take drugs that alter how the kidneys work. So, one common medication prescribed for high blood pressure, which is a common condition, are diuretics. Diuretics act on the kidney to increase the production of urine. A diuretic increases urine production. There's more than one way to do that. One of the more common kinds of diuretics is called a loop diuretic. Loop diuretics cause you to produce a lot more urine, but in the process you also lose more potassium. And that can be a problem. If you've got a person whose potassium levels are already low, then if you lose even more potassium as a result of taking your diuretic, then you can end up with hypokalemia, not enough potassium in your body, which is also a problem. So there are some diuretics, which we call potassium sparing. A potassium sparing diuretic increases urine production without increasing potassium loss. One example of that is something called spironolactone. Spironolactone interferes with aldosterone. It blocks the aldosterone receptor. So think about what that's going to do. If I take spironolactone, I block aldosterone receptors, which means I will not add extra pumps and channels. That means I will not reabsorb extra water, so I'll lose that water in the urine. That's why spironolactone is a diuretic. By blocking aldosterone, it prevents aldosterone from increasing reabsorption of water, which means I lose the water. But notice, aldosterone also increases potassium loss. So if I take spironolactone, I increase my water loss without increasing my potassium loss. So we call it potassium sparing. There are a few others, but that's a nice example. So those are some examples of secretion and why it matters. Another, actually, going back to probenecid briefly, since probenecid blocks the secretion of penicillin, it also blocks the secretion of a number of other drugs and drug metabolites, which is why sometimes if people are taking blood doping for an athletic competition, they might also take something like probenecid, which prevents those drugs from showing up in their urine as much to try to avoid detection. Don't do that, but it's an interesting thing physiologically speaking. Okay. I don't want to talk a whole lot more about secretion because it's really very specific to the individual thing. And if you understand what we just talked about here, you should be able to understand anything else that comes up in secretion later as you study this more. So where I want to go next is into the topic of fluid balance, how it is that the kidney regulates how much water we keep or lose in order to maintain water balance. Okay, let's talk fluid balance. So, Our bodies are mostly water, and we take in a lot of water and we lose water. And it's important overall that over time, the amount of water I take in matches the amount of water I lose. If I take in water more than I lose it, I end up building up water in the body. And that can lead to problems. If I have too much water in the body, that causes high blood pressure by my blood volume being too high. It can disrupt electrolyte balances by diluting the concentration of electrolytes in my blood and extracellular fluid, things like sodium and potassium. It can cause swelling from all of that from that extra blood volume getting pushed out, filtering out into my tissue and making more extracellular fluid than I can handle. And it can cause some other problems too. Losing more water than I gain can also be a problem. That can lead to dehydration, where I don't have enough water. That can also disrupt electrolyte balances. It can lead to low blood pressure as my blood volume gets too low. It can lead to a number of issues, even with heat regulation and things like that. So overall, I want to make sure that the amount of water I take in is roughly balanced with the amount of water that leaves my body. That's the idea of fluid balance. As an example of problems you can get with water balance, in 2007, you may have heard there was a radio contest at a radio station called Hold Your Wii for a Wii. Back in 2007, that's when the Wii gaming console was the hot new thing, and it was hard to get one. So this radio station had a contest where the idea was whoever could drink the most water without peeing would win a Wii gaming console. They actually had people calling in saying this is a bad idea, but they said, that's okay. They signed a release form. So the person who came in second was a young woman, Jennifer Strange. She was 28. And she, it's unclear, but from what I could read, she probably ended up consuming something like 2 gallons of water in a relatively short time, maybe an hour or maybe 2, which is a lot, and she didn't urinate. So after the contest, she went home complaining that she had a severe headache, and an hour later she was dead. What happened to this poor lady is that as she drank all of that water, too much water intake without loss, since she wasn't urinating, that diluted the fluid around her cells. Her extracellular fluid became too dilute. In other words, its osmolarity went down. So normally the osmolarity inside and outside your cells is about the same, so water doesn't go one way or the other. But when she consumed all that water, the osmolarity outside her cells went down. That got more dilute. And remember, water goes toward the higher osmolarity. So all of that water is now moving into her cells, which causes the cells to swell up. In most of your body, that just causes edema. You get tissue swelling. But you do have one really important organ that has no room to swell. Your brain is encased in a hard, bony skull, which cannot expand. So as her brain swelled, she ended up with too much intracranial pressure, which killed her. So osmosis can be a problem. And this is an example of why fluid balance is an important thing to keep managed. Let's talk about where your body gets fluid, where it loses fluid, and then how your kidneys help with that. So let's talk about some sources of fluid gain. So how does water get into the body? Well, really, there's only one significant source, which is dietary. You drink water or consume foods that contain water. There's all sorts of interesting stuff about this. There's a common belief that in order to stay healthy, you need to drink, 8 16-ounce glasses of water a day. There's actually no scientific basis for that at all. No one can actually seem to figure out where that statistic came from. That's a myth. That wouldn't be an unreasonable amount of water to consume. That's a good amount of water. If you drink that, you'll probably be well hydrated. But there's nothing behind it that says that's actually necessary. In fact, you get a lot of water from your food. If you consume, say, watermelon, that's more than 90% water. You get a lot of water out of that. Now, not all foods are good sources of water, and certainly there are plenty of beverages that are not. I remember seeing Coca-Cola once advertised as a good way to hydrate, which it's not. The osmolarity of Coca-Cola is pretty high, so it's not actually a good way to get water to your body. But in any case, we do consume water, and that's the major source of water gain for our body. Glucose metabolism produces some water. Remember that equation, glucose plus oxygen produces CO2 and water. but it's not really a major source of water for our body. All right, so dietary input is the main source. What are sources of water loss? How does our body lose water? Now let's see, there's sweating. You can lose water on your skin when you sweat. There's exhaling. Every time you breathe out, some of that humid air in your lungs leaves your body, so that's a source of water loss. These two are absolutely mandatory. If you need to sweat and you don't sweat, you will overheat and die. And you do need to breathe out. If you don't breathe out, you can't breathe in, and you will asphyxiate and die. So you have no choice about these sources of water loss. Digestion is actually also a source of water loss. When you eat food, in the process of digesting it, your body adds a fair amount of water to your digestive tract. You put in slippery mucus, dilute enzyme solutions, acid in water. All of that is water added to your digestive tract. You get most of it back normally in your small and large intestines, but you do lose a little bit of water in the feces. So if you eat, which you do need to do sometimes, you can go a while without food, but not forever, then you will lose some water with digestion. This actually touches on a point of public health. People often laugh about the idea of diarrhea, but from a clinical perspective, diarrhea is dangerous. If you don't have access to good sources of water and electrolytes, diarrhea can kill you in hours. I actually almost lost one of my kids for this. We were on a trip to Kansas, actually, where I grew up. My older son at the time was very, very young. He was 1 or something like that. And it was one of those where we all got the flu at the same time on the trip. So everyone was down, fluids coming out of multiple locations in all of us. Now, in me, I'm big and I can afford to lose some fluid, although I will say that Gatorade has never tasted so good. But my little one at the time, now he was older than 1. He was probably 2 or 3. But he was little, and his body doesn't have a lot of reserve. And he got sick enough that not only was he losing fluid, he couldn't take anything in. If you put even a little ice chip in his mouth, he'd throw it right up. And pretty soon, within hours, he started to get lethargic. He started to kind of not be moving much. His eyes were starting to get a little sunken back into his head. And we recognized some of what was going on and got him to the hospital. And when we got him there, they said, yeah, he probably had a couple hours left, and then it would have been too late. It was scary as heck. Now, of course, they put him on an IV and saline, and in 15 minutes, he's fine. All his body needed was water and electrolytes. So here's the problem with diarrhea. In diarrhea, all of that fluid that you add to your digestive tract isn't getting reabsorbed. You're expelling it before reabsorption. So you're losing all of that water and all of the salts that you put in along with that water. And as you lose all those water and salts, your body becomes dehydrated very quickly. So, diarrhea is not a joke. If you don't have access to Pedialyte or Gatorade or salt and water or anything like that, it can be lethal in hours. In any case, so, digestion is a source of water loss even if you don't have diarrhea, a minor one. But, the final one, of course, is urination. And urination is necessary. You don't have a choice. You do need to get rid of those metabolic wastes, and they have to come out in water. But how much water they come out in is something your body can control, much more than it can control any of these. If you digest food, you do have to add some water to it. You normally get most of it back. But with urination, how much water you lose that way is adjustable. That's what we talked about with those hormones aldosterone and vasopressin. They are the ones that adjust this water loss. So, if I have taken in more water than I need, I can't choose to lose it in these ways. I can't sweat more to get rid of the water, and I can't breathe out more, and I can't voluntarily have diarrhea. But I can have my body say, okay, make the urine more dilute, lose more water in the urine. Likewise, if I'm not getting enough water, my body still has to sweat, exhale, and digest, but I can make sure that when I urinate, I keep as much water in the body as possible and make the urine as concentrated as I can, so I lose as little water as I can manage. So we produce urine of varying osmolarity. Human urine can vary between about 50 to 1400 milliosmolar. And a lot of times students have trouble with keeping track of what osmolarity means. So think about it. 50 milliosmolar means very little solute, which means very dilute. This is watery urine. At 50 milliosmolar, it would look pretty much like water. Completely clear, no odor. You'd have trouble telling the difference between that and water. At 1400, that's very concentrated. 1400 milliosmolar would be very dark yellow, very strong odor. That's when your body is trying to keep as much water as it can so it makes the urine as concentrated as possible because it doesn't want to lose any water in that urine if it can avoid it. So our body can adjust our urine between those points based on how much water we want to keep or how much we want to lose. Now, how it does that, that is the interesting question. I thought of something else cool that I wanted to go over before we get over how you make concentrated urine. So we mentioned that maximum urine osmolarity is about 1400 milliosmolar, which is the same as 1400 millimoles of solute, that's salts or whatever else is dissolved in it, per liter of urine. This is why you can't drink seawater and come away less thirsty. So let's talk about that. So here, I'll imagine I'm on my life raft and I don't have enough fresh water with me and I'm getting thirsty. And I look around and say, but I'm in the middle of an ocean. I'm in the middle of this gigantic body of water. There's water all around me. Let's drink some of that. So I'll take my 1 gallon bucket and I'll scoop up a liter of seawater. Sorry, not a 1 liter bucket. We'll scoop up a liter of seawater and we'll drink it. Now, you'll probably throw up. But let's say I drink a liter of seawater. Seawater is about 2,200 milliosmolar. So it's got about 2,200 millimoles of solutes per liter of seawater. Those solutes are mostly sodium and chloride, although there's all sorts of interesting stuff in seawater, including a small amount of gold, interestingly. But most of that 2,200 millimoles is salt. So if I take in 1 liter of seawater, my body has taken in 2,200 millimoles of salt plus about a liter of water. Okay. Now, I don't want the salt, especially if I'm already dehydrated. So my body says, I need to get rid of this salt. How can I get rid of salt? In urine. So my body says, all right, I'm dehydrated. I need to get rid of these 2,200 millimoles of salt that I just took in. So I'll make the urine as concentrated as I can so that I lose as little water as I can because I'm already dehydrated. So I took in my 2,200 millimoles of salt. My body says, okay, let's get rid of as much as we can in our first liter of urine. So, in 1 liter of urine, I can get rid of 1,400 millimoles. So, in the first liter of urine, so I take in my 2,200 millimoles of salt and 1 liter of water. I produce 1 liter of urine, which is 1 liter of water and 1,400 millimoles, which leaves me 800 millimoles of salt still in my body. But I've already gotten rid of all of the water that I took in. Remember, I drank a liter of seawater, and now I've gotten rid of a liter of urine, so that's 1 liter of water in, 1 liter of water out. But I couldn't get rid of all of the salt. I've still got 800 millimoles more salt to get rid of, which is going to take me a little more than half a liter of water to get rid of at maximum concentration. So when I drink that seawater to get rid of the salt, I have to get rid of about 1.5 times as much water as I gained. In other words, drinking seawater will dehydrate you as your body has to get rid of the salt that you took in. Now, that's why humans can't hydrate themselves on seawater. There are some other animals that can. Chinchillas, if you're familiar with them, they can make urine at something like over 7,000 milliosmolar. So in theory, they could drink seawater and get rid of the salt in less water than they took in, so they would overall gain water. Humans cannot do that. If you saw the Kevin Costner movie Waterworld, I kind of wondered if he had evolved to do that. I wanted to get a look at his kidneys, but unfortunately that was not a part of the film. Okay, let's talk about how we make concentrated urine, or actually how we vary the concentration of our urine. So I've sketched up here an unfolded nephron, Bowman's capsule, proximal tubule, loop of Henle, distal tubule, collecting duct. This particular nephron is one of the ones that has its loop of Henle going down deep into the medulla. So here I've drawn the border between cortex and medulla. And what we're going to focus on here is what's going on here in the collecting duct. Now, hopefully you remember from the previous lecture, we talked about the effect that vasopressin has on these cells in the collecting duct. Just to really quickly sketch it up again, if I took a close-up look here, the cells of the collecting duct are normally not permeable to water, but they do have these aquaporins, the water channels, in their basolateral membranes out on this side, while they don't have them in the apical membrane. They do have vesicles with aquaporins waiting in the cell. And the hormone vasopressin causes those vesicles to move up and join with that apical membrane. So when vasopressin is present, there's a way for water to move from the lumen, that's the inside of the tube, all the way out here, the outside of the tube. Now, in the presence of vasopressin, the cell becomes permeable to water. Hopefully you remember that. If not, go back and look at that previous recorded lecture. Now, another thing that we have mentioned is that here in the medulla, the extracellular fluid out here is saltier than typical for the body. If we were to put in osmolarities, typical body fluid, typical extracellular fluid, has an osmolarity pretty close to 300 milliosmolar. Here in the medulla, it starts that way. But as we go deeper into the medulla, it gets saltier, up to a maximum of about 1400 milliosmolar by the bottom of the medulla. Now, why it gets saltier as we go down, why the osmolarity gets higher, that's the topic for part B of this lecture. Right now, just for now, just take my word for it. The osmolarity of the extracellular fluid out here gets higher as you go deeper into the medulla. Now, the stuff coming out of the distal tubule, the stuff that's going to be urine, comes out at an osmolarity of somewhere around 100, maybe even a little lower, maybe 50 to 100. So imagine this fluid now coming down to here. Now, between the lumen, the inside of the collecting duct, and the extracellular fluid out here, there's an osmotic gradient. And you know water tends to go toward the higher osmolarity. So here, there would be a tendency for water to leave and come out from the urinary tubule and into the extracellular fluid, where it can get picked up and taken back to the body. But if these cells are not permeable to water, it can't. So let's imagine several scenarios. If there's no vasopressin, that means these cells are not permeable to water. Those aquaporins have not been put into the apical membrane. And in that case, the water can't leave. So this osmolarity will not change all of that water is going to stay in here, and what's going to come out is lots of dilute urine. I'm going to lose all of that water in the urine. So this means large volume of dilute urine. I will pee out a lot of water in that case. So hopefully you see why that is. Without vasopressin, these cells are not permeable to water, so the stuff coming down here doesn't lose any water, and that water leaves the body. It's excreted. Here is where we're joining onto the renal pelvis, to the ureter, to the bladder, on out. So that's scenario 1, if there's no vasopressin. What about scenario 2, where there's lots of vasopressin? If there's lots of vasopressin, then all of these cells become permeable to water. So now let's imagine what happens as we come down here. So, if all of these cells have become permeable, this stuff at an osmolarity of 100 sees this as an osmolarity of 300, and the water will move out, drawn out by the higher osmolarity. Now, it's tempting to say that will make this more dilute, lowering this osmolarity. As it turns out, our vasa recta, those blood vessels that come up here alongside the collecting duct, will intercept that water and take it away, so that this number doesn't change very much. How does that work? We're not going to get into that. I'm going to say it's the magical vasa recta water fairies. So, the actual answer is it's kind of complicated, but maybe some other time. So, as this loses water, it'll keep doing that until it reaches osmotic equilibrium. Now it doesn't lose any water anymore. But now it moves down, and now it sees a higher osmolarity out here. So water is drawn out until it reaches equilibrium with that. And then it moves down, and there's a higher osmolarity out here. And water is drawn out, and you get the idea. So if there's a lot of vasopressin, so that all of these cells become permeable, then we reabsorb all of this water. So lots of water is reabsorbed, and I produce, as I've lost all that water, now there's not much fluid in here. What's left is very concentrated. So I produce a small volume of very concentrated urine. That's what I'll want to do if my body is low on water and I want to get the water back. Remember, any water I reabsorb here stays in the body, is not lost in the urine. Okay, so those are two scenarios: no vasopressin and lots of vasopressin. And the end results of that are a huge amount of very dilute urine at 50 to 100 milliosmolar, or a small volume of very concentrated urine at 1400 milliosmolar. Most of the time, I don't want either of those. Most of the time, I want a kind of moderate urine. So how am I going to do that? Well, bam! Now, as it turns out, the cells here in the collecting duct, they do respond to vasopressin. Vasopressin makes them permeable. But they don't all have the same sensitivity to vasopressin. The cells up here are more sensitive to vasopressin, meaning it doesn't take much vasopressin to get them to become permeable. The cells down here are less sensitive, meaning you have to give it more vasopressin to make them respond. And they get less sensitive as you go down. So let's think, what if we give it some vasopressin? Not none, but not a huge amount either. So if I produce some vasopressin, then the very sensitive cells, that's enough to get them to respond, so they become permeable. and maybe these two, but somewhere we'll get to a point where that's not enough vasopressin to get them to become permeable, and they don't put their aquaporins in. Let's say, just as an example, that that line is here. So when I produce some vasopressin, we'll call this scenario 3. Some vasopressin. Let's say that this is the point where that's enough to make the cells up here respond to it, but not enough to get these cells to respond. So as my fluid comes down, sees this, yep, there's vasopressin here, so we reabsorb water there and reach 300. Here, yeah, these cells have responded to the vasopressin, so we lose that water. And these cells have responded. And maybe, okay, by the time I get to here, I can't lose any more water because these cells haven't responded to the vasopressin. They're not permeable. So this high osmolarity can't affect me. Meaning, I'm now going to produce a moderate volume of somewhat concentrated urine. I get partial reabsorption. And I produce moderate volume of somewhat concentrated urine. The more vasopressin I make, the more of these cells will respond. In other words, that line will go down and my urine will become more and more concentrated. The less vasopressin I make, the more this only affects the most sensitive cells, and I'll produce more dilute urine. So vasopressin is like a dial, making us bring the area that I can reabsorb water further and further down the collecting duct so that I reabsorb more water. Summary there, more vasopressin leads to more reabsorption of water, which means less urine volume and higher urine concentration. So I want to give you some things to think about on that. Kind of a challengey question. Let's imagine some numbers here. So let's have something here that says amount of vasopressin needed to make those cells permeable. We'll say here it's 1 unit, 2 units, 3 units, 4, 5, and 6. So if my pituitary gland puts out 1 unit of vasopressin, that's enough to get these cells to respond, but not the rest of them. If it put out 4 units of vasopressin, that would be enough to get these, and these to respond, but not those. So if I put out 4 units of vasopressin, roughly what urine osmolarity would I observe? Okay, 4 units of vasopressin means these cells respond, which means all of these osmolarities can act on the urine. So I'll be pulling out water all the way along here, but not here. Meaning I would probably produce urine at about 900 milliosmolar in that case. Okay, that's challenge question number 1. Here's challenge question number 2. Imagine that we change this. Dr. Leguber decides this is too complicated and decides to make all of these have the same sensitivity. All of them have a sensitivity of 3. They all require 3 units of vasopressin to respond. What would be the urine osmolarity if my pituitary put out 1 unit of vasopressin? At 1 unit of vasopressin, is that enough to get any of them to respond? I don't think so. So none of them become permeable, and the stuff that comes out is at about 100 milliosmolar, large amount of dilute urine. What if they would do 2 units of vasopressin? Same situation. 2 units is not enough to activate any of them, so I produce large amounts of dilute urine, about 100 milliosmolar. What if I put out 3 units of vasopressin? 3 units is enough to activate all of them. So they all become permeable. I reabsorb water all the way down the way, and I produce tiny amounts of very concentrated urine at 1400. So notice in that case, I don't have any intermediate options. I'm either activating none of them for 1 or 2 units of vasopressin, or all of them for 3 or more units. It's like having a volume dial on your stereo that has 2 settings, 1 and 10, or 11, depending on if you're familiar with Spinal Tap. You can either go tiny, very soft, or very, very loud. Here, that would be maximal reabsorption or minimal reabsorption, but nothing in the middle. Might be an interesting test question. Okay, now, that's how we use vasopressin to adjust our urine osmolarity, by adjusting how much of the collecting duct is permeable to water, so how much this medullary osmotic gradient can pull water out and bring it back into the body. In the next part of this lecture, we're going to talk about where that came from. How do I get that salt gradient? And as a preview, that's what the loop of Henle of certain of your nephrons is for. See you then.